Mason. Okay. Okay. Hello, welcome. Bonsoir, good afternoon. Thank you everyone for joining us today. We are very excited about the conversation ahead of us. I'm Allison Carlson. I'm the Executive Vice President at Foreign Policy. We're based in Washington, D.C., and we're thrilled to be here with you today at such an important global convening. It's my pleasure to welcome you to this conversation that is both critical and timely, focusing on prioritizing diagnostics on the global agenda. As we move forward from the shadows of the COVID-19 pandemic, we find ourselves at a critical juncture, a point where our collective action can shape the health and well-being of millions of people around the world. Today's discussion is focused on that issue, and it's crucial to our global health system's resilience and pandemic preparedness going forward. And a key to that is access to timely and accurate diagnosis. Today is particularly significant as the World Health Assembly member states are convening today and tomorrow. We're waiting patiently and excitedly regarding the resolution on diagnostics. This resolution stands to shape and strengthen our global health infrastructure and the way we address diseases around the world, making this gathering tonight all the more important. But we're not just talking about diagnostics, but their vital role in strengthening healthcare ecosystems around the world, and by extension, health, well-being, and economic security, nationally and globally. Historically, the accessibility gap for diagnostics has not been terribly visible, and thus it hasn't been prioritized. But in 2021, the Lancet Commission, some of whom who are responsible for pioneering a report, highlighted that nearly half the world is not accessing diagnostic services. That's nearly half the world's population. And when you think about low and middle income countries, that's 81%, according to the Commission, that have no or limited access. And this limited access is contributing to a potentially avoidable 1.1 million deaths annually around the world for diseases like HIV, TB, hepatitis, syphilis, hypertension, and diabetes. But in the face of these challenges, there is a tremendous opportunity. Innovative approaches to financing, technology, and workforce development can help bridge this gap. But that's only if we prioritize, fund, and scale the solutions, some of which are already being implemented. It's in partnership with Roche that we convene you today and underscore the urgent need for equitable access to diagnostics around the world. And this conversation and the ones that follow will be about exploring strategies and partnerships to realize this goal. So welcome to all of you. Thank you to Roche for your partnership. And I also want to welcome our virtual audience who will be joining us from around the world. So I encourage everyone, those in this room and those online, to join in the conversation today. We, of course, are also on social media, so if you'd like to join in the conversation, and particularly if you're online, please do so using the hashtag Diagnostics, 4 for global health. Thank you all for being part of this discussion, and let's kick it off. I'm very excited to welcome our first speaker and a conversation today with Peter Sands, Executive Director of the Global Fund. Peter, welcome. Peter, thank you for joining us today. we know you have a very busy schedule, so really appreciate you taking the time.
I hadn't realized that diagnostics was such a hot item.
It is an incredibly
we're
hot
got a
item.
sellout crowd here.
We have a packed room and standing in the back and a few people seated and screens outside, and also, as I was mentioning, our audience joining in. So thank you all for making this a priority in your day as well, particularly with so much going on. I'm excited to kick off the conversation today with you and your perspective with the Global Fund. I know you've been working for a few decades now on HIV, tuberculosis, malaria, and I'm wondering how, from your perspective and drawing on that experience, what are some of the lessons learned there that can apply to the need for equitable diagnostics around the world as we think about greater pandemic preparedness?
Well, first of all, thank you for giving me the opportunity to join this session. I'm assuming I'm preaching to the converted, because otherwise you wouldn't be here if you didn't think diagnostics were important. But as somebody who's not a clinician or a scientist, it seems to me it's a fairly basic question, which is, if you don't know what's wrong with someone, how do you have any chance of being able to help them get better? And yet, far too often, we fall at that first hurdle. And indeed, the 1.1 million figure of avoidable deaths that you just mentioned, I was just doing the math in my head. At the moment, we have in TB alone about 3 million cases a year which are not diagnosed. And total deaths in TB is about 1.6 million. So it strikes me, if we could solve the diagnostic problem in TB, that alone would account for most of that 1.1 million. And I haven't even started on HIV and the others. So I reckon the 1.1 million number is an underestimate of the potential prize we could gain from having much greater access to high-quality diagnostics. As you say, within the world of HIV, TB, and malaria, diagnostics are absolutely vital. TB, actually, diagnostics are the single biggest issue. They are the limiting constraint on how effectively we fight TB. With HIV, diagnostics play an absolutely vital role, and indeed innovations around self-testing are critical to overcoming, or at least finding a way to mitigate the damage due to stigma, discrimination, criminalization, impediments that stop people seeking access in health facilities. But also viral load testing is critical to ensuring that antiretroviral treatment actually is working. And on malaria, actually we benefited from the fact that we have had wide availability of very cost-effective diagnostics that are very simple to administer. But unfortunately now we're beginning to see with gene deletion the parasite finding ways round those diagnostics. And that actually illustrates the potential downside of when you rely too much on something and you're not thinking ahead about how things are going to develop, because if you start having a pathogen able to get around your diagnostics and disguise itself, then you've got a real problem on your hands. But one lesson I think is worth drawing on. We were the largest providers of diagnostics to low and middle income countries during the COVID crisis. We had a mechanism called C19RM, the COVID-19 response mechanism. We're not terribly imaginative in the Global Fund about how we call things. Was how important it was to have the infrastructure there already. And so a lot of low and middle income countries' ability to do, say, PCR testing for COVID-19 was based on the infrastructure that was already there, particularly for TB and HIV. It was the same instruments, it was the same laboratories, it was the same lab technicians. And actually, you can't, when a new threat emerges, you can't just instantly create that infrastructure and expertise. You have to have it in place already. And so I do think we need to think, when we're thinking about diagnostics and pandemic preparedness, we have to think, what we do for the diseases we face right now today is the foundation for what we will have when encountering new threats.
Thank you for that. And you said a few things that I'd like to pick up on, including what has been learned from COVID-19 and the way you've approached TB, for example. And we find ourselves in an environment where we are emerging from, still not out of, and may not be for some time, COVID-19, but also in the midst of a number of other global challenges that are certainly interconnected and linked, including a global debt crisis, especially in low and middle income countries, impacts of climate change, and other geopolitical challenges that are complicating response. And so I'm wondering, the term polycrisis came up in the World Economic Forum and elsewhere. To deal with these complex challenges, how can diagnostics and investments in diagnostics be prioritized amid those other challenges, and also in a way that, you spoke to this a bit, how the approach isn't siloed to just tuberculosis or just HIV. How can that response be integrated and benefits be gained, across communicable and non-communicable diseases?
You're good at asking small, easy questions.
It's a framing conversation, so it's a bit of a broad one.
I mean, this is the essence of the problem. We have a lot going on in the world at the moment, and much of it isn't very good. But one thing I think we've learned in an increasingly sort of information-driven world is knowing what's going on. Joining the dots between things is a massive advantage. It allows you to target your interventions and understand where the pressure points are. And we're still flying blind in a lot of medicine. We still don't know what's going on. And I'm afraid, like COVID-19, testing has collapsed right now. So actually, most countries have very little idea how much COVID-19 is around. The best thing we have at the moment is in places where we have wastewater surveillance, because at least then we get a population estimate of what is happening. I do think we have to put more priority and visibility on diagnostics, particularly in a resource-constrained environment, because we can't afford to waste money. We can't afford to treat people who don't have diseases. We must focus the effort on the areas of greatest burden, and you can only do that if you're using effective diagnostics. But we also need to drive the technology of diagnostics in a number of different ways. For one thing, the holy grail of multiplexed tools. So we have, what you want is tools in primary healthcare facilities that allow you to do very sophisticated molecular type of diagnostics across a range of different conditions. And you want the cartridges to be costing cents or very low single-digit dollars. Because if they cost more than that, you end up not using them as much as you need. The second thing, which is more of a sort of conceptual thing, but is where we ought to be going, is at the moment, most diagnostics are designed around answering binary yes-no questions. Does somebody have malaria? Does somebody have HIV? What we really want to get to is a diagnostic approach which says, what's wrong with this person? Now, that's a much harder question to answer, but ultimately that's the question that clinicians, healthcare workers are interested in, and frankly, the patient themselves is interested in. And then the third thing I think we need to move faster on, and there are lots of great innovations around this going on, is how we actually capture the data and therefore use it to understand the epidemiology of any threat. RDTs are great, and the fact that they were pushed out into communities and for self-testing in COVID and so on was a fantastically helpful thing. But we lost all that data because very few people actually bothered to inform anybody that they tested negative or they tested positive, right? And the more we can get into an environment in which or into a technology mode in which these devices are essentially giving the answer to some system. It can be anonymized, it can be protected, but at least that generates a huge amount of epidemiological data, which could be enormously helpful. So I think and this is where I think the private sector has massive, there's a huge scope for innovation. The only thing I'd say is it's all got to be absolutely dead cheap, which I know those of you who've got shareholders won't like. But it's true, if we are going to really make these sorts of tools accessible to the poorest people in the world, who are the ones most at risk from the deadliest infectious diseases, we got to make it very, very cost effective.
And to that end, to drive down cost for those interventions that do have the highest impact and are able to identify what's wrong with this patient or what's wrong with this person coming into a clinic, what are some of the partnerships that are necessary to do that in order to invest in innovation and drive and accelerate those costs to make those interventions more accessible? I know the Global Fund has been working on a number of public-private partnerships and with a number of other organizations, and I'm wondering if you can pinpoint a few examples that are working. What are examples that can be drawn upon?
The first point I would make is that you can only do this through partnerships, because this is a complex set of technology, implementation, sort of behavioral and attitudinal things you have to overcome if you want to improve access and effectiveness of diagnostics. And no one organization has everything needed to make that happen. The Global Fund is a partnership. I mean, we operate by working with governments like the government of Benin. We operate with civil society. We partner Roche, for example, on sample transportation, as well as all the technology that Roche produces. We operate with other agencies like FIND, the Foundation for Innovative New Diagnostics, with Unitaid. So we need all those partnerships. I think the thing that we need to bear in mind all the time is all the fancy kit and all that kind of stuff is not worth anything if it's not actually saving lives, reducing infections, improving the well-being of people. Ultimately, the test is the impact on the people. The second thing I would say is that sometimes in the world of global health, and I confession here, I don't come from the world of global health. I come from the nasty world of bankers and financiers and things like this. But one thing the nasty world of bankers and financiers do understand, one thing they understand is that time is money, and that if you can do something faster, you make more money. Now, in our world of global health, actually time is lives, and we are often too slow. And there were, certainly in the COVID response, there were a number of things that happened in the world of diagnostics which drove me absolutely mad because they just simply weren't happening fast enough. And we could have saved more lives if we had moved faster. And that's the same. That's the same with the existing diseases. 150,000-ish people are dying of tuberculosis every day. If we can improve diagnostics for that, and we can improve it next month as opposed to 6 months from now, that's real. And so we need the partnerships, but the partnerships need to be always focused on the end outcome, which is the impact on people, and they need to be driven by a sense of urgency.
Very well put. Thank you. And many of the topics that you raised we'll be diving into in just a few moments. But thank you for your time and your work, and appreciate you being here.
And I must apologize because I'm now actually going to another event which is all about diagnostics as well, which is the HIV Prevention Coalition. And one of the most critical elements of HIV prevention is actually enabling people to know what their status is. So I'm going to apologize, but thank you very much for giving me
Thank you very much. What a great introduction and way to frame this next conversation. Now we'll move on to our panel discussion. I'd like to invite to the stage Dr. Alawade Alakija, Special Envoy for the Access to COVID-19 Tools Accelerator, the ACT Accelerator, from the World Health Organization, Ann Costello, President, Roche Diagnostics Solutions, and Dr. Lindawe Makubalo, Assistant Regional Director for the African region for the World Health Organization, and Kent Ranson, Senior Economist for Health at the World Bank. Pardon me. Pardon me, thank you. We have a small stage, and we're excited to have everyone join. Join on this. I will try not to topple off. Thank you all again for joining us. We're really excited to dive into some of the issues that Peter Sands framed for us very well. We have an esteemed panel here with decades of experience working at the front lines of these issues. And so, Alawade, I'd like to start with you. Alawade, Yodi. Pardon me. You've been working with the ACT Accelerator and directly with FIND. And I am wondering how, in your experience, how you can apply and what comes immediately to mind for some of the lessons learned in the last few years and how they pertain to the context of diagnostics and what needs to be prioritized in this moment.
Well, thank you very much. It's also a real pleasure to be here with everybody, and also likewise, like Peter, to have such a full room. I mean, let me first of all clarify my role. First of all, I'm Special Envoy to the Director General of the WHO and co-chair of the Access to COVID Tools Accelerator. So I don't actually, because it looks like you've got two WHO people on stage, so I don't actually work for WHO. I'm just a Special Envoy, which is an ambassadorial role. Type of role, and then I chair the accelerator, which includes Peter. It includes Peter Sands, but also includes FIND. And so the other role is that I'm the chair of the board of FIND, which is the alliance, soon to be Alliance for Diagnostics, and that is important. That distinction is important to answer your question. The Access to COVID Tools Accelerator really. It did do one thing. It accelerated the visibility of diagnostics in this world during the COVID pandemic. I mean, what we had during COVID was, I loved what Peter just said about time being money, but also time being lives. And had we, and this I have said numerous times, that had we had more access to diagnostics all over the world, we would definitely have saved millions more lives. There were now an estimated 22 million excess deaths from COVID. I want to stress that COVID is not over, and yet we still also don't have access to diagnostics. So again, as Peter said, people don't know their status, and yet for those of you in the sort of banking world, and for those who think about economy and money, which is absolutely critical to all of us, we're losing sight of the livelihoods and the productivity being lost because of a loss and a lack of diagnostics. So the Access to COVID Tools Accelerator was a sort of a grouping of, well, I call them the big nine, the 9 big boys in global health. And Peter might say he's not a global health person, but he is one of the big 9. And the big 9, of course, include my brother over the road, Dr. Tedros, include, Gavi, Global Fund, CEPI, all the big organizations. And what the world did was bring them together. So if we go back to the HIV/AIDS analogy, and there's some of us HIV veterans in the room, what we saw in the years of HIV was we didn't necessarily have that right at the beginning. So yes, there was critique of the ACT Accelerator, and before I became, and still am, one of the most ardent critics of what the ACT Accelerator did not achieve. But we must look at the counterfactual and look at what it did achieve, and that had we not had the access to eventually to the diagnostics and the acceleration of organizations such as FIND, who work together with about 50 partner organizations around the world to bring us diagnostics. I remember the early days where we had to we had to push for EUL, the emergency listing of the self-testing, like Peter was saying, for HIV, ditto for like HIV, like COVID. If we didn't have self-tests in many of the countries of the world, how were people going to be able to protect themselves? So, I see that in one of the reasons, quite frankly, that we're here today. In addition to people like His Excellency, the Eswatini, Kingdom Eswatini ambassador, and countries who came together to push what is going on over the road with the diagnostics resolution. But COVID and Act A and the diagnostics part of Act A pushed that forward. So that is the positive. Where are we going with this? It depends on how we as a global health community, and a global community, not just health, choose to implement what we're talking about. I wrote notes about when Peter was talking, and he was talking about the 145,000 people who die every day of TB, and we're forgetting those numbers, but we're also forgetting that some of the things that happened during COVID was in South Africa. They were doing testing for hypertension at the same time as doing COVID testing at taxi ranks for cab drivers, of which 62% didn't know that they had hypertension. In my country, Nigeria, less than 2% of people who have hypertension know. How are we going to treat these diseases if we can't find them? Pun totally intended. How are we going to manage our economies if we can't treat or prevent disease? Prevention is better than cure. So those are some of my and then, of course, women. I can't stop without talking about women. If we talk about HPV, women dying absolutely every day, and the tragedy of it, and breast cancer, in the countries that I've lived in, Nigeria, Fiji, Malawi, various parts of the world, women have no access to testing. I have seen patients, personally myself, whose breasts were open sores. And the stench in the room, that's often the how most people in the Pacific Islands in the years not long by knew that they had breast cancer, because for want of a basic diagnostic test. So for me, these are issues that are up front, and as the world has fewer and fewer resources, we have to start to recognize that if we pick the low-hanging fruit, if we deal with diagnostics capacity, if we deal with primary healthcare systems, then we're going to not have to spend the gazillions that we're ultimately trying to spend on high value sort of therapeutics at the end of the day. Time is money. Diagnostics saves lives and saves money.
Thank you for that and that framing, and shedding light on the realities that people are experiencing due to the lack of access and the absolute need across, and how inequitable that access is in many parts of the world. I'd like to bring you in, Lindiwe, about your perspective and teeing off of those comments. You're focusing on the African region in your work, and I'm wondering how you're seeing issues related to inequitable access to diagnostics manifesting there, and the priorities of the WHO in addressing them.
Well, thank you so much for having me. And it's such a pleasure, and I think already the discussion that we've had has just been so on point and so exciting. I don't have my technical colleagues here with me, but I felt I really ought to join this conversation, because it's really an opportunity for us to be reflecting on what we should be doing, and what we've learned and how we go forward. As you said in your opening remarks, about half of the world's population doesn't have access to diagnostics, and at least I think 80 to 90% of those are from lower middle income countries, and a large proportion of that I believe would be when men, women, children in the African region. And so the African region is really in a place where we feel we need to be jumping into this conversation, and we're so pleased that the resolution that is being discussed at WHO is a resolution which has really been championed, so to speak, by a country from the African region, Eswatini and others, because we really feel that we have an opportunity to make a difference now. Post-COVID, we have learned quite a lot, and I think it's not only learning in terms of the figures, who has access, who doesn't, and is it men, is it women, but also just learning. You mentioned equity. I think just bringing to life and reminding ourselves that the issue of equity is a real issue, and learning that what we cannot. I think it's Tedros who's often likes to say, what is the phrase again? He says that if not everybody is, can't remember the actual.
It's
What does he say?
opportunity is talent is universal, opportunity is not, something, one of those.
Something to that extent. But basically saying if I don't have access, you have access, we are not winning. We all need to have access. And I think that what is happening, we have an opportunity now in the African region. I'll basically go through what I think many of us know, and that is we have serious infrastructure challenges. We are really on course, trying our very best to meet the UHC SDG targets and achieve universal health coverage. That cannot be done. From what you've been saying, what we've all been saying, what Peter Sands was saying, if we don't have diagnostic capacity, we don't have access. We don't have access. You cannot treat if you don't know where the problems are. And so really the threat to achieving universal health coverage is a real one. We have infrastructural challenges. Our health systems need a lot of work to be done, and the diagnostic services, diagnostic aspect of the health system strengthening is a real one. And so maybe I thought I should highlight today that it's a real problem, and I won't repeat the statistics that we've already shared. But in the African region, we really, really believe that we have an opportunity. Now, what is it that we can do? I think others are going to speak to it, but really the partnerships are going to be very important. We definitely need partnerships. I think the resources, financing is a huge hindrance to achieving diagnostic services. Now, we know most governments, whether you're talking about low-income countries, middle-income countries, even the more resource countries, I think that at the moment we are all saying resources are limited, but we have to find solutions on how to, to make the difference. So partnerships are going to be very important because we definitely need to ensure that we can have diagnostics. But then I think we can be a little bit more creative. We need to be talking about market shaping, for instance, transfer of technology so that we can have within the region, and of course not only the African region but other regions as well, that we can then basically be able to have better capacities to develop diagnostic capacities. We saw what happened during COVID in terms of genomic sequencing, and if we didn't have just a sudden. Okay, let me just begin with the capacities that were in Southern Africa, particularly South Africa and neighboring countries. But, that work really propelled us forward. So I think that there are opportunities, and I'm keen to hear. I think I have a few more suggestions in terms of what we could be doing in terms of partnerships, but I think others are going to come in. But really the resources are a huge challenge. So finances, and again, of course, human resources, human capacity, but you cannot have capacity if you don't have the finances to train and to basically put in place the sort of capacities we're talking about. But I'm really keen for us to get into some of the solutions. So I'll stop here and maybe have an opportunity to come back, but I'm looking at my World Bank colleague next to me. I'm sure we'll have solutions coming from you.
Great. I love the solutions-oriented focus and hope that the rest of our conversation can be focused not on the challenges, but on what's working, what is being done that is actually accelerating action and implementing change on the ground. I'd like to pick up on one of the first things you said and then come back to a few of the others regarding financing. But Anne, first I'd like to turn to you. When we're talking about access and equity and driving down costs and enabling diagnostic solutions to be deployed around the world, you've been working specifically on that, on access and solutions for diagnostics. And so I'm wondering, as you focus on low and middle income countries, what are some of the lessons learned that you can point to, and what's working, and how can we further, democratize diagnostics?
So also, it's a pleasure to be on this panel, and it's a great conversation. It's a very much needed conversation around diagnostics. For the longest time, diagnostics has been undervalued, and I think we now have an opportunity with the resolution to really get that out there. So very, very supportive of that. I think one of the things I would say is the way to democratize diagnostics is really to strengthen the diagnostics capabilities, capacity. And by that, the infrastructure, and that's what I'm talking about. And the infrastructure is so important. We saw that through COVID. Not having the infrastructure in place was a huge impediment for us, right? And it wasn't just in the low and middle income countries. We saw this even in developed countries, right? Because they were not prepared. So I think first and foremost, that is really important. I think we also have to think about the complexity of diagnostics. It's really a complex business. We're talking about having lab capacity, because the only way you can deal with volume is really having labs that can process high volumes, right? And when you think about the number of people, when we're talking about something like TB, malaria, and so on, that's what you need. And so in terms of capacity and infrastructure, you need labs that have the appropriate equipment, that they are set up with processes, that they have quality control in place. Because at the end of the day, you're dealing with patients' lives, right? We can't afford to make a mistake. So that's really important. You need to have trained people, so the staff have to be trained. And I think the other thing that's really important when we talk about the infrastructure is, it's not just one and done. You have to sustain that over time as well. And by that, I mean, you need to have that continuous quality process in place. You need to be able to maintain and service the instrumentation. You need to get the samples to the labs, right, for that high quality diagnostics. And by that is, having the logistics in place to be able to take the samples at the right point from the patients, transport them to the lab, but then you need the IT infrastructure in place that allows you to send back the results, and the clinician can take the appropriate action for the patient. So all of these things have to come together to make really a diagnostic infrastructure really happen. And I think it's having all those building blocks in place at the time makes it work. And I think that's where we really are focused in on that. One of the things that we can contribute is really helping to set up labs, to organize labs, to make sure that we optimize the workflow, that we have quality controls in place, that we can train people. We actually have in South Africa, we actually have a scientific campus where we actually do training of scientists and medtechs to allow them to be able to have the skill sets that are needed to manage the labs going forward as well. So that's really important from my perspective as well, that we make that available. So
Great. And you all mentioned infrastructure and the need for it. And now I will turn to you, Kent. From your perspective, and also in your role as a senior economist with the World Bank, and specifically focused on health, in what has already been mentioned, a resource-constrained environment, and one that desperately needs capital. And capital for a number of things, including healthcare infrastructure. How are you thinking about that, and what are you prioritizing as a first part of the question, and understanding that it will take some innovative financing mechanisms to be able to deploy capital, particularly into low and middle income countries? What are you focused on?
So let me first thank the organizers and say what a pleasure it is to be speaking among such esteemed panelists. I do feel bad, though, for being the one member standing in the way of a womanal. So achieving universal health coverage will require all stakeholders to work together, and Lindy Way referred to the importance of all hands on deck and us working in partnership, public and private sectors alike. Most developing countries have mixed public-private healthcare systems. In sub-Saharan Africa, over 50% of all healthcare interactions take place in the private sector, and this number is 80% in Asia. So effective use of public-private partnership models can help to extend the breadth of services, extending the reach among underserved populations, and improving the quality of care. And you've also referred to the importance here of driving down costs, including of diagnostics. I can provide some examples during COVID of how we've extended partnerships. In the former Soviet Republic of Georgia, for example, where more than 85% of hospitals are private, at the beginning of the COVID pandemic, the government negotiated a compensation package with private providers, opening up the additional capacity required as the number of cases of COVID increased. South Africa, similarly, contracted with private facilities to build in surge capacity for ICU beds. Outside of COVID, many countries have deployed private-public partnership programs to enhance their healthcare infrastructure and provision of healthcare services. These include Brazil to Turkey, Romania, the Kyrgyz Republic, Uzbekistan. And this covers both specialized services such as diagnostics, advanced imaging, outpatient services, and in some cases, inpatient services. Those countries that I've cited are all countries that have received support from the International Finance Corporation, which is one part of the World Bank focused on the private sector in low and lower middle income countries. I'd also like to mention the Health in Africa initiative, which was launched by the World Bank Group in 2009 with support from the Gates Foundation. That initiative has created a private equity fund that has to date invested over $500 million US dollars in the private health sector across Africa. The fund invested in small and medium-sized private health organizations, and in so doing has increased access to quality private sector health-related goods and services. Finally, I'd like to mention the work of the Global Financing, the Global Financing Facility for Women, Children, and Adolescents. This is a multi-stakeholder global partnership housed at the World Bank, and it's supported PPPs in many countries. In Côte d'Ivoire, for example, the GFF has supported improved data on the health sector, updated regulations for a modernized system for licensing private facilities, the review of laws and regulations governing the private sector, and draft private sector engagement policy and strategic plans.
Okay, thank you for that. You're focusing on infrastructure, and it's important to emphasize both the public-private partnerships and also make the case and understanding of what the returns to those investment on public dollars are, and private dollars as well, the returns to health, and also the returns to local communities, and the economic impact that can have as well, and the cascading impacts, which we referenced before. And in addition to the infrastructure, it comes to mind the importance of last mile service delivery. And how are we able to reach the communities directly and to those who need it most when, even if there is a manufacturing facility, even if there are logistics in place, which are challenging, how can we ensure that last mile delivery so the most vulnerable can actually be accessed? And so I'd like to turn back to you, Ayowadi, to focus in on that issue, and from your experience, how can that be ensured even if and when there is expansion of infrastructure to, again, ensure that last mile delivery?
I think last mile service delivery is very much linked into the strength of our health systems. It's very much linked into primary healthcare systems. If you don't have primary healthcare systems that are strong, you can't reach last mile, whether you're in a high-income country or a low-income country. It also, I say to people all the time that I like practicality and simplicity. I think we can sometimes get too highfalutin. If you want to get to people at community level, you have to work with communities, you have to talk to communities, you have to find out what those communities want. And I mean, we've heard a lot about building blocks today, and I actually made notes that said building blocks requires strong health systems. What diagnostics, going back to diagnostics and that last mile delivery, what diagnostics affords us is true potential for UHC, universal health coverage. Why? Because diagnostics, everybody, even in low-income countries, people will pay for their lives. They will pay for good health if they feel like that is going to prevent them from, I mean, many of our countries, people are hyper-religious because you have to go to church or to the mosque to pray forever because you don't have a doctor. Really, I mean, not that people wouldn't pray anyway, but, you know, most of the prayers are about, God, keep me safe. God, please make sure that I'm not spending all of my money on the hospital or the doctor because I want to be safe. Imagine all the money that people are spending on giving offerings or whatever it is, if they were able to take $1. I'm looking at my brother, the minister here. If you were able to take one of those dollars and you were able to pay for a diagnostics test that was not also a single test, if you didn't have to pay $1 for each test, but you could pay, you know, you desilorized, as it were, the testing, and you could check your family ever so often and make sure that you were keeping yourselves safe. But that also requires investment. It requires investment. You know, the world's charity model, I will say, is very much broken in our global health world. So it requires investment also from, not just from outsiders, not just from private sector critical, but also requires investment, and I'm looking very much at Monsieur le Minister, it requires investment from governments in low-income countries. You know, I'm Nigerian, you know, the Abuja Declaration of 2001, Africa said we were going to spend 15% on health. If we built the basic infrastructure and then we then partnered, and if our governments and our leaders actualize that commitment of 15%, I believe Botswana and one or two others are the only countries doing it at the moment. If you had the basics of electricity in a primary healthcare system, so that somebody, if there was a test, they were able to run those tests. If we had the very, very basics, then I believe that diagnostics would truly be an issue for, you know, when you said the hashtag diagnostics for all, we could really begin to talk about diagnostics for all, because until we get to that last mile, there is no point in having, during COVID, for instance, let me use that example, I had to pay $100, $150 for a test in Abuja, in Nigeria, where I live. I mean, I couldn't afford it, never mind, but there weren't any testing centers in rural areas. So let me again bring it back to today. Omicron, and my sister Lindy talked about, you know, the diagnostics capacity and the genomic sequencing in Southern Africa. That got us into trouble because when we did the hard work of sequencing, then the world locked the door and said, you can't come back in, we're short of time, you know. But that diagnostic capacity exists in our centers of excellence. We need to cascade it down, but it is only our own governments that are able to build the enabling environment, the water, power, the infrastructure that it is needed. And then we come to our partners and we say, join hands with us. Private sector, absolutely critical, but private sector also partnering with local and regional manufacturers on our continent. Thank you.
Thank you for that. And I'd like to pick up on that note with you, Anne, and talking a little bit more about the private sector and the partnerships that Roche is working on specifically to enable last mile delivery. What are your priorities and what are some examples that you can point to?
Yeah, absolutely. No, I totally agree that, you know, primary care in a country is absolutely critical. And, you know, for us, when we talk about integrated diagnostics and laboratory capacity, we're also talking about point of care where you need it, and as well as having laboratory capacity. It goes hand in hand, actually, because you want to be able to get to that last mile. I think the other thing is, you know, having that type of infrastructure plate. You don't need a lot, right, for point of care, and you know, but you do need to be able to confirm some of those things, and that's why the laboratory capacity is super important as well. So that's why we do work with partners to make sure we're looking at it in a holistic way, not just, you know, the piece in in the lab or the piece that you have close to the patient. It's how do you bring it together? I think the other thing that's important, I mean, we know that everybody has a mobile phone. So how can we send results back in a good way? Right? And we have done this in the past with HIV, where, you know, people want to have the privacy. They want to see their results on their phone. They don't want to have to go and discuss it. So there's many, many ways that we can impact that. And if I talk about, you know, the partnerships, you know, this is why we have partnered with the Global Fund. We made a partnership with them last year because exactly that, right? They have the infrastructure, they're working with the right people. Nobody in private sector can do this alone. This is all about working together in partnerships with stakeholders and making sure that, you know, we bring the strengths of our partnership together, right? And that combined strength and expertise will make a fundamental difference. And that's why we have chosen to work with multiple partners. We also are working with other partners. We have our own global access program, which we started for HIV, actually. And through that, we have expanded that program to include other things like TB, like hepatitis, like cervical cancer. I mean, we've talked about women's health as well. No woman should die from cervical cancer. The technology is there. The technology can get to the people. But we need to make sure that those screening programs are in place, because we're talking now a lot about sick people. But actually, the most important thing is to keep people healthy, right? Because that's what changes the game. That's what keeps people in, you know, in the economy and working and being able to contribute. So what's really important for us is to think about how do we make sure that we're touching all parts of diagnostics, not just when people are sick, but much earlier in the process, where we can do screening and make sure that they have the care upfront that they need as well.
And keeping people healthy requires a workforce.
That's right.
And, you know, I go back to the Lancet Commission study, and I believe they said about 840,000 workers are needed. There's a shortfall and gap of a significant scale to address the workforce shortages that are needed. And those are jobs, that's training that's necessary, those are additional investments that are needed. And so, Linda, I'm going to turn to you, and I know we're running short of time, and there's so much to dive into. So fortunately, we have time after this to continue the conversation. But I'd like to turn to you, and when you're thinking about the workforce and those on the ground and on the front lines who are delivering the tests, and who, many of whom need to be trained, especially if there is going to be the deployment of additional technology and use of mobile phones, digitization of healthcare, et cetera. How do you think about that from the perspective of the World Bank, and what more can be done to focus on workforce strengthening?
Well, I think a whole lot can be done, and I think to begin with, I think it's important that we don't think in siloed ways. We've been talking about strengthening of health systems, but you have, you know, those who are working in diagnostics and putting resources into diagnostics. We need to find ways, not only for national governments, of course, but across the board, to say, how can we better put resources into strengthening health systems much more broadly, which would include the health workforce. Mm-hmm. One of the criticisms I think that most of us had of ACT Accelerator, and I mean, you know, we were all part of it, is that we brought in the health systems component rather late, and probably not enough effort into the health systems component. So I think those investments are going to be very important up front, right across the board, in terms of strengthening the health system, but in a very focused way. And I think the health workforce is one area where it's very clear, you know, the investments that are needed. I think there's been lots of many pieces of work that have done that, investments on the financial side, but also understanding the different skills mix and so on that are required. So I think this is an important area that we can focus on and have very tangible results, because really I think at the end of the day, as we've been saying, we cannot achieve. And it's not just about achieving universal health coverage. Like, so what is that exactly? I think exactly what we've been saying, reducing mortality, improving quality of life, you know, reducing morbidity, and I think that's what we need to be aiming for. So stop there.
I think you all said it very well about investing in people and their health and their well-being, and specifically as it pertains to women, which many of you mentioned as well, and Kent, how you mentioned priority projects really focused on women, especially understanding that they make up the majority of the healthcare workforce as well. So just to underscore that and the need for that kind of prioritization for equity, including access. Unfortunately, we've run out of time, and so we'll need to stop there, but this is not, of course, the end of the conversation. Thank you all for joining us today and for the work that you continue to do. Dr. Alakija, Ann Costello, Dr. Makubalo, and Kent Ranson, thank you again for joining us today.
Thank you so much.
Thank you so much.
I thought she was going to say, how are you going to finance it?
I think that's safer. So many important points and issues to dive into. And now I would like to welcome to the stage for some remarks the Honorable Benjamin Ignace Bondaren Honkpaten for joining us today. Thank you. We welcome you to the stage. The minister will be providing his remarks in French, and we will have simultaneous interpretation. Thank you so much for joining us.
Bonsoir, je voudrais avant toute chose vous remercier pour cette opportunité que vous nous offrez de discuter d'un sujet d'une importance capitale. Tout à l'heure, dans les discussions, j'ai cru entendre l'importance de l'engagement politique. Et ça, à l'instar des pays de la sous-région ouest africaine et du monde entier, le Bénin a connu son premier cas de Covid-19 en mars 2020. Mais à ce moment, les outils de diagnostic étaient rares et peu de laboratoires étaient outillés car la plupart des équipements de biologie moléculaire étaient fermés. Et le gouvernement du Bénin, prenant la mesure des choses, a commandé en urgence, grâce à l'appui de la Banque mondiale, justement, qui avait un projet qui était en cours au Bénin, le projet REDICE, du matériel de biologie moléculaire afin de mettre à l'échelle 14 laboratoires, du coup, de biologie moléculaire et de surveillance épidémiologique, facilitant ainsi donc un large accès au diagnostic à la population avec une gratuité du traitement dans les 12 départements que nous comptons. Nous avons 12 départements au Bénin, 12 régions au Bénin. Et chacune des régions avait un laboratoire de biologie moléculaire. L'ensemble des partenaires, y compris le Fonds mondial, à travers le financement C19RM, ont emboîté le pas à cette initiative. Et un renforcement de capacité du personnel a été réalisé, parce que c'est très important, grâce à la mise en place d'un dispositif de transport des échantillons également qui a été mis en place. Et cette montée en puissance avec les différents comités de gestion a été rendue possible grâce au partenariat. Et ça a permis de contenir la propagation de l'épidémie, parce que je pense qu'on a entendu parler du Bénin, de l'exemple du Bénin dans beaucoup de forums. Et en plus des 14 laboratoires, on s'est rendu très vite compte qu'il fallait aller plus loin. Et le Bénin s'est doté de 3 laboratoires P3, on n'en avait aucun au moment de la pandémie. On a eu 3 laboratoires P3, dont un mobile pour une réactivité plus accrue face aux épidémies. Soulignons que, comme je disais, nous avons déjà fait face à beaucoup d'épidémies. La fièvre Lassa, la dengue, on n'a pas eu l'Ebola. Et puis récemment, il y a le virus de la variole du singe qui est venu. Et la technologie mise en place et renforcée avec la COVID-19 a permis de nos jours de réagir assez vite en matière d'exploration biologique, mais il demeure quand même la mise en place d'une surveillance génomique. C'est capital aujourd'hui. Compte tenu des pathogènes avec la métagénomique, des virus, des bactéries, devant toute situation de nouveau, afin de permettre une réactivité dans les délais les plus courts. Aujourd'hui, c'est un défi. Un approvisionnement régulier en intrants également, le maintien des compétences au poste, le renforcement de capacité, la maintenance fondamentalement la maintenance et la métrologie, constituent un défi permanent pour le gouvernement du Bénin, qui doit compter sur le dispositif mis en place pour donner l'alerte en un temps réduit et faire à temps la riposte. Je vais laisser traduire.
Thank you. So first of all, ladies and gentlemen, I would like to thank you for the opportunity of having the opportunity to talk about such a pivotal topic. And I heard talking about the importance of political commitment earlier today. And about that, I would like to say that as many other countries in the sub-region, Benin experienced its first case of COVID-19 in March 2020, but diagnostic tools were scarce and few laboratories were properly equipped as most molecular biology structures were closed. Recognizing the emergency, the government urgently ordered, and thanks to the support of the World Bank, molecular biology equipment to expand its 14 molecular biology and epidemiological surveillance labs, enabling broad access to diagnosis for the population with free treatment in our 12 departments. The technical financial partners, including the Global Fund through the COVID-19 response mechanism, followed the government's initiative. The capacity building of staff was carried out alongside the establishment of a sample transport system inspired by the system we had already in place for epidemic management with various technical committees. Our increasing capacity combined with other measures made a real contribution to containing the spread of the epidemic. And in addition to the 14 laboratories, Benin understood it had to do more. And this is why it acquired 3 more P3 labs, one of which was mobile, to improve its ability to respond to the epidemic. It should be noted that Benin has faced other epidemics such as the Lassa hemorrhagic fever, the dengue fever, no Ebola, fortunately, but more recently also the monkeypox virus. And the technology put in place and strengthened after COVID-19 now allows us to respond fairly quickly in terms of biological research. But there is still a need to set up continuous genomic surveillance, which is of the uttermost of importance to follow the spread of pathogens and bacterial metagenomics in the face of any new situation on the ground, and in order to do this in the shortest period of time. The regular supply of inputs, the maintenance of skills at the different posts, the capacity building, the maintenance, and the metrology are key and still permanent challenges to our government. It still relies on the system in place to give the alert in a very short time to facilitate the implementation of any response.
L'accès au diagnostic pour les personnes vivant dans les pays à revenus faibles ou intermédiaires est une question critique dans le cadre de l'amélioration de la qualité des soins, d'une réponse efficace face aux épidémies, et demeure une question morale et d'éthique. Cela a été souligné tantôt. Ce gap mérite d'être corrigé progressivement si nous voulons vivre ensemble dans un monde plus juste et plus équitable. Par ailleurs, du fait des mouvements intercontinentaux, du niveau de plus en plus accru des échanges entre les diverses populations et de la vitesse de propagation des pathogènes, il urge de rendre un accès plus équitable au diagnostic partout dans le monde, et surtout dans les pays à revenus faibles ou intermédiaires, afin d'assurer une sécurité sanitaire mondiale. Ces objectifs sont difficilement atteignables du moment où, 1. Le développement de ces outils se fait uniquement dans les pays industrialisés. 2. Le transport et la conservation en cours de transport des réactifs grèvent énormément les coûts d'acquisition et sont soumis aux aléas. Au cours de la période 19, on l'a constaté avec l'impossibilité d'avoir des transports où le prix du transport était trop exorbitant. Et 3. La technologie pour la fabrication et la maintenance des équipements est détenue par très peu de pays. Et pour atteindre ces objectifs, donc, il serait donc opportun que les pays à revenus faibles ou intermédiaires accèdent aux outils diagnostiques, équipements et réactifs à des coûts abordables. Que les pays à faible revenu ou intermédiaire réduisent les coûts et les délais d'acquisition des outils en travaillant à faire développer les 10 outils sur leur propre sol. Ça va être contributif. Que les pays industrialisés aident les pays en voie de développement à développer par eux-mêmes les technologies de ces outils, transfert de technologies. On a vu pour la vaccination, on a eu le développement de vaccins sur des sols africains, et puis ça peut se faire pour les outils diagnostiques également. Et enfin, que les pays à revenus faibles ou intermédiaires puissent maîtriser et mettre en place un système systématique de maintenance des équipements de laboratoire.
Access to diagnostics for people living in low and middle income countries is a critical issue for improving the quality of care and responding effectively to epidemics, and this remains a moral and equity issue. This gap must be progressively addressed if we are to live in a more just and equitable world. Furthermore, due to intercontinental movements, increased exchanges between different populations, and the speed at which pathogens spread, there is an urgent need for more equitable access to diagnostics, especially in low and middle income countries, if we are to ensure global health security. These objectives will be difficult to achieve while, 1, the development of these tools takes place only in industrialized countries, 2, the transport and storage, also during the transportation of reagents, represents a huge burden in terms of acquisition costs, and that this transport is subject to uncertainties. We have seen it during COVID when costs related to transportation were prohibitive. And 3, the technology for manufacturing and maintaining the equipment is in the hands of very few countries. To achieve the objectives, it would therefore be appropriate for low and middle income countries to have access to diagnostics tools, equipment and reagents, and this at an affordable cost, obviously. Secondly, low and middle income countries should have the possibility to reduce the cost and time of acquiring tools by working to develop them in their own countries. This would be uttermost helpful. And industrialized countries, 3, should help developing countries to develop the technology for these tools themselves through technology transfers. We have seen it's possible for vaccines, because vaccines have been produced in Africa. It is also possible for diagnosis tools. And finally, low and middle income countries need to manage and implement systematic systems for the maintenance of lab equipment.
Le développement des outils de diagnostic et leur distribution pour un accès équitable dans nos pays doivent faciliter la couverture sanitaire universelle à toute la population, prenant en compte un certain nombre de paramètres. Premièrement, je pense que la mise en place d'outils fiables, rapides et précis et de coûts abordables est indispensable. Ensuite, le développement et la mise à disposition des outils point of care, tout à l'heure ça a été souligné et c'est indispensable, surtout au niveau des unités de soins périphériques ou des niveaux de diagnostic de première ligne. Le renforcement du plateau technique des laboratoires existants par une politique de mise à disposition d'équipements de pointe garantissant un accès rapide aux examens et aux diagnostics de qualité dans un bref délai, peu importe la situation géographique de l'individu. Le développement de systèmes ouverts pour un accès plus flexible et plus large aux réactifs et aux autres intrants. Le développement des tests de diagnostic rapide et leurs technologies dans les pays à revenus faibles ou intermédiaires. La délocalisation de la fabrication des réactifs et des équipements vers les pays du Sud afin de garantir leur disponibilité en tout temps. Le développement des technologies dans les pays du Sud. Le renforcement de la maintenance des équipements de laboratoire par la formation professionnelle spécialisée et la mise en place de véritables centres ou entreprises de maintenance. Le développement du partenariat public-privé, et ça également, ça a été souligné, c'est indispensable dans les approches de décentralisation et de développement des technologies, lorsqu'on sait d'ailleurs qu'au moins 50% de notre population est soignée par le secteur privé. C'est seulement vraiment en nous mettant ensemble que nous pouvons vaincre le défi d'un monde plus sûr pour chacun et pour tous, afin que nul ne soit laissé de côté.
The development of diagnostic tools and their distribution for equitable access in our countries must facilitate universal health coverage for the entire population, taking into account several points. And I do think about, well, the introduction of reliable, rapid, and accurate, as well as affordable tools. They are key. Furthermore, point-of-care tools need to be developed and provisioned, especially at the level of healthcare units or first-line diagnostic levels, as it was said earlier. The technical facilities of the existing laboratories need to be strengthened through a policy of providing state-of-the-art equipment to ensure rapid access to quality testing and diagnosis within a short time, regardless of the geographical location of any individual. We also need to develop open systems for more flexible and wider access to reagents and other inputs. The development of RDTs and their technology in low-middle income countries is key. Furthermore, relocating the manufacture of reagents and equipment to the south to ensure availability at all times is essential. Basically, technology development must happen in the south as well. We need to strengthen the maintenance of lab equipment through specialized vocational training and the creation of a genuine maintenance center or companies. And finally, we need to develop private-public partnerships, as it has been said earlier, because this is key. We need decentralized approaches to technology development, especially given that the private sector accounts for more than 50% of the beneficiaries in our country's health facilities. Long story short, it is only by working together that we can meet the challenge of creating a safer world for all, leaving no one behind.
Ce n'est pas qu'un rêve, ça peut devenir après une réalité. Je vous remercie.
It is not only a dream, it can become true.
Merci. Merci. Thank you, Minister. You know, as you said and underscored, the importance of public-private partnerships, but then one of your last points about the decentralization of solutions. While we've talked a lot about lessons that can be learned and applied to low and middle income countries in particular, context matters, and the unique situations and dynamics in countries and communities matter. So thank you for sharing your experience and perspective from Benin. We really appreciate it. And thank you to all of our participants for sharing your expertise and ideas about solutions and what can be done. I know many who are in the audience, both here in person and also who are online, are working on these issues day in and day out and care deeply about this. And I'm really excited to be part of this convening and also hopefully a conversation that will continue outside and move forward in terms of collaborative action. You know, we've discussed today the pivotal role of diagnostics in global health and strategies to expand access, the focus on equity, but again, the urgent need for action. We couldn't be in a more important and timely place for that, and as the resolution on diagnostics is being discussed, it's urgent and it's critical, and it's such a timely opportunity to advance these conversations now. So thank you for your expertise in adding depth to this conversation, and again, really focusing on solutions and what can be done. As Dr. Alakija said, the hashtag, continue the conversation, diagnostics for global health. We at Foreign Policy also want to continue these convenings. We're dedicated to evidence-based, research-based conversations and continuing to convene experts, practitioners, policymakers, and others for greater action. So thank you for being with us today. Looking ahead, I'd love you all to tune in to a Global Health Forum. Foreign Policy is convening on June 13th. And then I know we're also all looking ahead to the UN General Assembly in September, where much of the action will be carried forth and a major focus will be on universal health coverage, on antimicrobial resistance and global health security and pandemic preparedness. And I think what's really been underscored today is none of those goals are possible and won't be achieved without a real focus on diagnostics. So thank you for your work and being part of it and being part of this conversation today. That's all for the program. As I mentioned, please join us outside. I'm sorry those joining online can't join with us, but encourage you to continue the conversation. Thank you for being with us today.